let's have the slides for the next group.
It's on. It's on. Can everyone see the slides? It should be on by now.
Yes, I see it.
Okay. Blank pa lang.
Chronic
Blank. Ayan,
diarrhea.
okay.
Before. Okay.
Okay, let's start. So first speaker.
Okay,
First
so
presenter.
good morning. Good morning, doctors. Good morning, classmates. We are subsection B4 and we are here to present the approach to a patient with chronic diarrhea. So just a brief introduction about our patient. She is a 40-year-old female who is an NGO volunteer with a chief complaint of diarrhea for 2 months. And these are the salient features that we found in the case. For the subjective salient features, we have the age, the gender, the travel history to Bangladesh, loose, mushy, and mucoid stools in which our patient has been passing out for about 3 to 5 times a day in the last 2 months prior to consultation. And as we all know, mucoid stools is typically seen in bacterial infection. However, since the patient is having the diarrhea for more than a month, we could easily rule this out. The presence of mucus could also be a sign of anal fissure, bowel obstruction, or it could also be indicative of IBD like Crohn's disease or ulcerative colitis. Patient is also having low-grade fever, which could indicate that there was an inflammatory reaction taking place in the body of the patient. It was accompanied by crampy hypogastric pain, which could be a cause of chronic swelling or irritation. The patient also self-medicated with metronidazole, 1.5 grams daily for 1 week, which provided temporarily relief. However, after 3 days, there was recurrence of diarrhea and crampy hypogastric pain, which was then accompanied by blood-streaked stools, and this could be a sign that there is a presence of lower GI bleeding. Patient also has a history of minimal pulmonary TB, which was managed with anti-COX medication for 6 months. So moving on for the objective findings, our patient is about 160 centimeter tall and 45 kilograms. And after computing her BMI, we got 17.6. And using the Asia Pacific BMI classification, the patient falls in the underweight category, which is less than 18.5. Her BP and pulse rate are both normal. However, 90 beats per minute can be considered a bit high. The patient also had pale palpebral conjunctivae, which indicates possible anemia. In the rectal exam, there was rectal tenderness and fresh blood was seen on the examining finger, which again could tell us that there may be possible lower GI bleeding. Other physical exam findings were basically normal. She had clear breath sounds. Her cardiac exam was unremarkable, and in the abdomen, it was soft with no tenderness, no palpable mass noted.
Okay, hello. Can you hear me?
Yes.
Hello.
Okay,
Okay.
go. Carlo.
So I'll be discussing a short discussion on chronic diarrhea. So diarrhea is a passage of abnormally liquid or unformed stools at an increased frequency, and it's at a greater than 200 grams per day volume. And chronic, if the diarrhea lasts for more than 4 weeks. And the major causes of chronic diarrhea are the secretory, osmotic, steatorrheal, inflammatory, desmotile, factitial, and iatrogenic causes. Um, I'll be discussing each of these points.
Just a comment, Carlo. Just a
Yes.
comment. So these are not actually causes. These are the mechanisms of chronic
Okay.
diarrhea. No, so they're not actual diseases that cause chronic diarrhea. No, these are the mechanisms of chronic diarrhea. Okay.
Okay, put down.
Okay.
Okay. So beginning with secretory diarrhea, its mechanism and presentation is as follows. It's a derangement in fluid and electrolyte transport across the entire colonic mucosa, and it's characterized by a large volume, watery, and typically painless diarrhea that persists through fasting. Its causes may include medications, bowel resection, mucosal diseases, enterocolic fistulae, and hormonal uh, imbalances. As for the osmotic diarrhea, its mechanism is of a poorly absorbable, osmotically active solutes drawing fluid into the lumen, exceeding the resorptive capacity of the colon, and it characteristically ceases with fasting. Caused by osmotic laxatives, carbohydrate malabsorption, wheat and FODMAP intolerance. Um, for the steatorrheal diarrhea, its mechanism is fat malabsorption, leading to greasy, foul smelling, and difficult to flush diarrhea. And the patient may present with weight loss, nutritional deficiencies, and upon examination may have greater than 7 grams per day of fat in the stool. And it's caused by intraluminal maldigestion, mucosal malabsorption, and postmucosal lymphatic obstruction. For inflammatory diarrhea, its mechanism and presentation are as follows. Its exudations, fat malabsorption, and impaired fluid and electrolyte absorption, and presents as hypermotility, pain, fever, and bleeding. And its key point is leukocytes in the stool. And it is primarily caused by idiopathic IBD, primary or secondary immunodeficiency, and lymphatic obstruction. For dysmotile diarrhea, its mechanism and presentation are as follows: rapid transit, and the stool analysis would be similar to secretory diarrhea, and it also presents with mild steatorrhea. It is caused by irritable bowel syndrome, visceral neuropathies, hyperthyroidism, prokinetic agents, and post vagotomy operations. And as for interstitial diarrhea, it is its mechanism is self-administered laxatives or adding fluids to stool before analysis, and it might be caused by Munchausen or eating disorders. So for the approach to a patient with chronic diarrhea, um, first, when a patient presents with chronic diarrhea, we must exclude an iatrogenic problem. So this would be medications or surgeries such as vagotomies, cholecystectomy, ileal resection, or bariatric surgery. And
Carlo, we
uh,
have a request here.
yep, yes,
Please open your camera so
okay.
that the facilitators and your classmates can see you.
Medyo magalo yung buhok ko, Doc. Sorry.
Okay lang yan. Sige. Open your camera, then okay, continue with your presentation.
Continue, please.
Please continue. Hello?
Next meeting na lang po yung camera.
Sorry. Nag-lag
Okay.
yung phone ko,
Okay.
Doc. Sorry.
Okay,
Okay,
sige.
so,
Okay, go.
to repeat,
Continue.
I'm gonna go into sunlight lang, Doc, para makita niyo ko lang. Okay, yeah. So, for the patient with chronic diarrhea. So, when a patient presents with chronic diarrhea, you need to exclude iatrogenic problems such as medications and surgery. So, this includes post-vagotomy operations, bariatric surgery, cholecystectomy, and ileal resections. And then following that, you need to observe the patient and see what they present with. So if there's blood per rectum, you might want to order a colonoscopy or a biopsy to see if there are any masses or any malignancies within the patient. If the patient presents or explains that he has fatty characteristics of diarrhea, you might want to investigate the small bowel through imaging, biopsy, and aspirations. Um, if the patient mentions pain through bowel before bowel movement and the pain passes or is relieved after the bowel movement, you might want to suspect irritable bowel syndrome. And if the patient has no blood or features of bowel absorption, you might want to consider more of a functional cause of the diarrhea. So this includes your malabsorption, like celiacs. So you might want to recommend dietary exclusions for like lactose and sorbitol. And then following these initial screenings, you might want to extend your screening further by investigating hematology, chemistry, the CRP, the ESR, the FE, folate, B12, the stool for excess fat, and calprotectin. So, um, if you observe that the patient has low hemoglobin, albumin, abnormal mean corpuscular volume, or uh, mean corpuscular hemoglobin, or excess fat in the stool, you might suspect a gamut of diseases. So for low albumin, you might expect an inflammatory sort of disorder. Um, and with these, you might want to be investigating through a colonoscopy or biopsy. And again, small bowel X-ray or a biopsy aspirates and stool 48-hour fats. And following the small bowel or the stool 48-hour fats, you'll further classify the patient whether or not the fat exceeds greater than 20 grams per day, because then it might present as more of a pancreatic excrement insufficiency, leading to intraluminal maldigestion. Um, Further, with those limited screenings that we give to our patient, we might find electrolyte imbalances such as a low serum K. This might be more of indicative of secretory diarrhea, such as what can be found in the VIPoma, which is also known as the medullary carcinoma of the thyroid, which might present with hypokalemia, hypomagnesia, hypoglycemia, hypocalcemia, flushing, or hyperglycemia. And following that, you might want to investigate further to find the stool volume, the osmolality, the pH of the stool, whether or not the patient had any prior use of laxatives through fecal magnesium. And you might, and if the secondary screen, no,
Carlo, can you fix your audio, please?
opioid reactylate or loperamide, and if this is a persistent diarrhea that does not respond to or follow, you want to investigate the full gut transit, and you might want to titrate the action of the treatment speed of the patient's transit, because they might have a faster than normal.
Hey, Carlo, we have problems hearing you.
Also want to take the 48-hour
Nawala na.
for the algorithm
Hello,
approach to the patient with
Carlo,
chronic
are you
diarrhea.
there?
This
Can you show us your next slide? Okay, let's go to the next speaker.
Yeah. Carlo is having internet connection issues. Can we just
Sige, okay.
go to the
Next
next?
slide. Okay. Next presenter.
Good morning po, Doc. So next will be the
Morning. Go.
definition is your inflammatory bowel disease, which consists of your ulcerative colitis and Crohn's disease. The common manifestation between the two includes your chronic diarrhea, passage of mucus, abdominal pain, and in some cases fever, which are all present in our patient. For the next consideration is your malabsorption. There are a lot of causes for malabsorption that will be again presence of loose stools. Next will be your irritable bowel syndrome. This was considered because in general clinical manifestation of it includes your abdominal pain and the presence of diarrhea. So the another differential diagnosis is your ileocecal TB. It was considered since there is diarrhea, abdominal pain, presence of fever, which are all present in our patient. Taking also consideration that in the past history of the patient, there is PTB, which can predispose the patient to gastrointestinal TB, but this is an uncommon extrapulmonary manifestation of your TB. You can exclude or rule out your ileocecal TB since there is no palpable abdominal mass upon physical examination. And according to Harrison's, the abdominal pain is in time similar to appendicitis, but in a non-specific location. But to our patient, the abdominal pain is described as a crampy in the hypogastric region. Next is your neuroendocrine tumor, which could include a metastatic gastrointestinal carcinoid tumor or medullary carcinoma of the thyroid. Although uncommon, Doc,
Yes.
may nag-ask po ba? Or, oh,
Go ahead,
Continue.
hindi ko
Carlo.
lang po ba, Doc? Okay, Doc.
No, go
So,
ahead, go ahead.
So the diarrhea in your neuroendocrine tumor is of a secretory type of diarrhea, which could be watery type and painless in nature, which is different to our patient since our patient has a pain and a blood streak stool. Lastly is the parasitic infection, which can cause blood in your stool and abdominal pain and fever. But we can rule this out because in a bloody diarrhea usually occurs in acute infection, which in our patient we have a chronic type of diarrhea. Since acute type of diarrhea is less than 2 weeks, while your persistent is 2 to 4 and chronic is greater than 4 weeks. Yan. Okay na po.
Okay. But just a comment, no? As Dr. Khan would always say to us, no? For chronic diarrhea, lalo na in our setting here in the Philippines, you still have to consider, okay, infectious causes,
Okay po.
no? Rather aside from all of these things, okay? Yes, Dr. Ruiz.
No, as I've written in the comment box, no, in fairness to Carlo,
Okay.
we have not been hearing you on the last two slides. But if you want, you can present, yeah, this last slide if you want, Carlo. Just short
Okay,
one.
Carlo. Okay na yung audio mo, Carlo? Is your audio okay? Carlo?
Wala pa rin.
Wala.
Oh, we can,
Wala.
okay,
Let's
we can
proceed na.
go.
Okay. So, next presenter?
Uh,
Di niyo po, Doc.
just an additional point on the comment of infection as the cause of diarrhea. You have to categorize also that in acute diarrhea, infection is the number one consideration. In chronic diarrheas, however, that will spell now the difference as to the primary consideration. So among the infectious agents causing diarrhea, most of them would cause acute diarrhea, but not necessarily chronic diarrhea. So once it becomes chronic, then the list of differentials would differ. Okay.
Yes
Okay.
po, Doc. Thank you po, Doc.
Sige. Let's proceed.
Okay. Doc, di niyo po. So, good morning, doctors. Good morning, classmates. Let's proceed now to the first differential diagnosis, which is inflammatory bowel disease. So, I will be discussing the clinical manifestations and complications of inflammatory bowel disease. Ay, sorry, Doc, rinig po ba ako?
Yes, yes.
Yes.
Okay po. Thank you po. So, moving on. So first, what is inflammatory bowel disease? So inflammatory bowel disease is an immune-mediated chronic intestinal condition with two major types. So the first type is the ulcerative colitis, and the second type is Crohn's disease. The ulcerative colitis is confined to the colon and only affects the top layers in an even distribution, while Crohn's disease affects any part of the GI tract from the mouth to the anus. So the two are very since they are both chronic inflammatory bowel syndromes. They are also both marked by an abnormal response by the body's immune system and even share many symptoms. However, they have differences such as the ones that I mentioned. such as the location. And other than that, their differences will be discussed later on. So moving on,
Just
inflammatory
proceed to
bowel
the
disease.
pathogenesis. Just discuss the pathogenesis.
Okay po, Doc. So inflammatory bowel disease is the dysregulation of the following. So there are three factors. So if you look at the diagram, the first factor is the microbial flora in the left side of the diagram. So these are the commensal flora or the microbiota found in the GI tract. And the next factor in the middle of the diagram, is the intestinal epithelial cells or the IECs. And the third part is the mucosal immune system. So the dysregulation of these three will lead to the chronic inflammation that is typically seen in inflammatory bowel disease. So IBD is considered an inappropriate immune response to the endogenous commensal microbiota within the intestines, with or without some component of autoimmunity. All right. So next slide.
Okay.
So here's an illustration of Crohn's and ulcerative colitis. So I would just like to point out the differences in the location. So on the left side of the diagram, we have the Crohn's disease, and it's important to note that Crohn's disease is found all over the GIT, from the mouth to the anus. And I'll just be pointing out some of the more common locations. So the most common location is the ileocolic area, which is at the bottom left side. And after that, it may be found all over the small intestine, or typically the jejunoileitis area. So that's in the middle. And the next is the colic area. So the colic area is to the right side. So typically, a colic type of Crohn's disease may present similarly to ulcerative colitis. And also, it may present in the perianal area. On the other hand, we have the ulcerative colitis. So the ulcerative colitis is more limited in its distribution. It is continuous and uniform inflammation in the large bowel. So it's
Hello, I think this will be emphasized later by the other speakers. Okay,
Opo,
so
Doc.
let's
Sige po.
proceed. Your
So
next
next
slide.
slide. Okay. So I'll just go through this quickly. So the inflammatory cascade in inflammatory bowel disease. So this one, in this part, it is initiated by the parenchymal cells or the intraepithelial cells or the IECs, as well as the hematopoietic cells, specifically the dendritic cells that sense abnormal bacteria. So in the diagram, you'll see this purple dendritic cell in the middle, as well as the epithelium containing the IECs. So these are the ones that initiate the inflammatory cascade. And next, it is perpetuated by the T cell activation. So if you look at the diagram, the purple dendritic cell in the middle leads to the activation of the T cells. And after that, after the T cells are activated, the cascade is extended by inflammatory mediators. And these lead to the inflammatory bowel disease. So it is also important to note that 5-ASA as well as glucocorticoids may inhibit the inflammation. Okay, so the next slide. Next, we move on to the clinical features and complications of IBD. So these are the intestinal manifestations and complications of both ulcerative colitis and Crohn's disease. So first, on the left side, we have ulcerative colitis. Oh, but before that, both UC and CD, UC is ulcerative colitis and CD is Crohn's disease, are both associated with intestinal extraintestinal manifestations. Extraintestinal manifestations are usually related to intestinal disease activity and may precede or develop concurrently with intestinal symptoms. So while both of them have similar clinical presentations, some characteristic features, I will be emphasizing some of the characteristic features. So For ulcerative colitis, the most consistent feature of UC is the presence of blood and mucus mixed with stool, accompanied by lower abdominal cramping, which is most intense during the passage of bowel movements. Also, the presence of diarrhea with blood and mucus, as opposed to the absence of blood, is used to clinically differentiate between UC and irritable bowel syndrome. Also, UC is usually diagnosed earlier after the onset of symptoms than is TB because the presence of gross blood in the stools alerts persons to a gastrointestinal problem. And also, the location of abdominal pain depends on the extent of colonic involvement. So, typically in ulcerative colitis, since it affects the ascending colon until the rectum, the pain is present in the left lower quadrant. Yeah, and abdominal distension, guarding, and rebound tenderness to palpation with decrease in bowel sounds requires close supervision due to the risk of developing toxic megacolon. So, just to go through it quickly, toxic megacolon is an inflammatory bowel disease that causes the colon to expand, dilate, and distend. So, when this happens, it may rupture, and that may be life-threatening. So, one very serious complication of ulcerative colitis is toxic megacolon. And moving on to Crohn's disease, in contrast to ulcerative, yes, Pudo.
Yes po, Dr. Ra. Yes, Dr. Ra.
Yeah, just to simplify your presentation, you are not to discuss here UC per se or Crohn's per se. You are to discuss and point to us, to everybody, what are the differences, okay, in the clinical complications, clinical manifestation of UC and Crohn's.
Yes, Pudo. So, just to summarize the clinical manifestation of UC, so the pain is typically in the lower left quadrant po, as well as
So,
common.
wait. Are you differentiating the two, or you are discussing clinical manifestations of each?
I'm discussing the clinical manifestations and yung difference between the two po, Doc.
Yeah,
Oh,
don't discuss first the difference because another presenter will discuss the difference between the two.
Okay. Okay po, Doc.
Hindi ba yung nag-usap? Mga groupmates mo?
Doc, nag-usap po. Ito po yung part na assigned po kasi sa akin, Doc.
may assign ba sa differentiate UC versus Crohn's?
Yes, do.
Opo.
Okay.
Meron.
Oo. So siguro ito na lang.
Let's proceed.
Kasi wait ha, the problem, sino ba to? Si John ba to?
Jose Paulo po.
Wait.
Dino.
Paulo?
Yes, Doc.
Okay. Problem, Paulo, is when you present your discussion this way, it's like differentiating the two.
Yes po, Doc.
Yeah. So you just go briefly to the clinical manifestations without differentiating.
Okay po,
So you
Doc. Sige po.
finish your presentation. Go ahead. Wala kang
So,
numbering, no? Okay.
po.
Sige, go
Sige.
ahead.
Go ahead.
Okay. So, sige po. For ulcerative colitis, it may manifest as proctitis and colitis, and usually at the same time. So, proctitis is the inflammation of the rectum, and colitis is the inflammation of the colon. While Crohn's disease po, it may since it involves more segments of the GI tract, it may have more manifestations and includes the following. So first is ileocolitis, presenting with diarrhea, recurrent RLQ pain, palpable inflammatory mass, low-grade fever, as well as anorexia and weight loss. Next is the jejunoileitis, presenting with diffuse abdominal pain, malabsorption, steatorrhea, and anorexia. Next, you have colitis, presenting with low-grade fever, malaise, diarrhea, and crampy abdominal pain. It is also important to note that in colitis, it may have a similar presentation to ulcerative colitis due to its location. So it may present with and bloody diarrhea with mucus. And the last presentation of Crohn's disease is perianal, characterized by incontinence, hemorrhoidal tags and strictures, anorectal fistulae, and perirectal abscess.
Okay.
All right. And
Next
next,
slide.
we have the extraintestinal manifestations shared by both ulcerative colitis and Crohn's disease. So we have fever, seen in 40% of patients, and is usually low grade. Rarely, it may present as high grade, as it can be high spiking, but usually it is just low grade and unrecognized. Next, we have weight loss, which is observed more in CD than UC. We also have delayed growth and sexual maturation in children, and this is due to the inadequate nutrition, but it is more common in CD rather than UC. It can also present as arthritis and arthralgias. You can also have mucocutaneous lesions such as oral aploid ulcers, erythema nodosum, as well as pyoderma gangrenosum. Also, it may present as ophthalmologic complications, which may result from the IBD itself or from the corticosteroid therapy. It may also present as It may also manifest hepatobiliary disease, such as primary sclerosing cholangitis, but it is more common in UC. It may also present as renal disease, such as nephrolithiasis, and in UC, uric acid calculi is more common, while in CD, it is oxalate calculi. And lastly, we may also have bone abnormalities such as osteopenia, maybe due to IBD itself or corticosteroid therapy.
Okay.
Okay, Doc.
Okay. Next.
To differentiate ulcerative colitis from Crohn's disease. So first, let's differentiate the epidemiology of ulcerative colitis and Crohn's disease in different populations. In this slide, I compare two populations. One study was done with Caucasian population and the second study is done locally with the participation of Filipinos. So the mean age in Caucasians is 20 to 29 years old, with the first peak at second to fourth decades of life, and the second peak at seventh to ninth decades. While in Filipinos, the mean age is 40 years old. The first peak is at 21 to 40 years old, and the second peak is at 40 to 60 years old. In Caucasians, inflammatory bowel disease is not gender specific. However, in the Filipinos, there is a higher predominance in male, probably affected by the environmental exposure and genetic factors. And according to Harrison's, smoking and appendectomy has protective effects on ulcerative colitis, while it may cause the disease, Crohn's disease. Next. So for the macroscopic differences of ulcerative colitis and Crohn's disease, ulcerative colitis is a mucosal disease that usually involves the rectum and extends proximally to involve part of the colon. About 40 to 50% of patients have disease that is limited to the rectum, while in Crohn's disease, it can affect any part of the gastrointestinal tract, from the mouth to the anus. 40 to 55% have disease involving both the small and large intestines. So unlike in ulcerative colitis, which almost always involves the rectum is often spared in Crohn's disease. In ulcerative colitis, proximal spread occurs in continuity without areas of uninvolved mucosa. When the whole colon is involved, the inflammation extends 2 to 3 centimeters into the terminal ileum in 10 to 20% of patients. Crohn's disease, it is segmental with skip areas in the midst of diseased intestine. And as mentioned earlier, ulcerative colitis is a mucosal disease, while Crohn's disease is transmural that affects the whole layer of the affected part of colon. So endoscopically, ulcerative colitis undergoes mild inflammation. The mucosa is erythematous and has fine granular surface that resembles sandpaper. In more severe disease, the mucosa is hemorrhagic, edematous, and ulcerated. In long-standing disease, inflammatory polyps or pseudopolyps may be present as a result of epithelial regeneration. So here in this image, we can see a typical endoscopic features of ulcerative colitis. In picture A, it is classified as mild.
Can you show a pointer? Ira, use your pointer.
Here.
Okay.
In image A, it is classified as mild with mucosal erythema, fine granularity, decreased vascular markings. In image B, we can see moderate classification with mild erythema also and loss of vascular markings. In image C, this one, it is C and D are both classified as severe. In picture C, we can see ulcerations that are present. In picture D, there is the presence of spontaneous bleeding. And then for luminal narrowing with pseudopolyps, again as a result of epithelial regeneration. While in Crohn's disease, endoscopically, when it is classified as a mild disease, seen in picture A, there is an aphthous or small superficial ulceration. And in a more active disease, here in picture B, we can see stellate ulceration that fuse longitudinally. And then for picture C, we could see cobblestoning
Hello,
appearance, which is a
Ira.
character. Hello, Doc. For picture C po, we could see cobblestone appearance, which is a characteristic of Crohn's disease.
Hello.
For hello, Doc.
Medyo napuputol ka eh. Napuputol yung audio mo. Napuputol yung audio. Hello?
Hello po, Doc.
Okay ka na? Okay na yung connection mo? Ayan, sige.
Okay
Yung
naman
last,
okay
ano mo,
naman sa akin.
statement? Ano yung last mo?
For Crohn's disease po, we could
Okay,
see the
sige.
cobblestone
Okay.
appearance, which is a characteristic of Crohn's disease.
Okay. Sige. Next slide.
Wait lang, Doc. For microscopic differences, in ulcerative colitis, histology findings correlate well with the endoscopic appearance and clinical course of ulcerative colitis. The process is limited to the mucosa, with deeper layers unaffected except in fulminant disease. So there would be crypt atrophy and irregularity or distortion and superficial erosion. Some patients may have basal plasma cells and multiple lymphoid aggregates, which may suggest chronicity. In Crohn's disease, the earliest lesions are aptoid ulcerations and focal crypt abscess with loose aggregations of macrophage, which form non-cacheating granulomas in all layers of the bowel wall, which sometimes form fistulous tracts and local abscess. Granulomas are characteristic feature of Crohn's disease. There would also be the presence of submucosal or subserosal lymphoid aggregates.
Yes po, Dr. Yes, Dr.
Yeah.
Ruiz.
Ira, can you go back to
Hello?
your slide on the differences between UC and CD? Can you present to the screen another one? Back, previous to this. Okay. Wait. No, next one. Ito na ba yun? Meron ka pang isang slide eh. Can you go to your first slide and then first slide? I think this is the one. Okay. Bowel wall. Okay, look at the bowel wall between UC and Crohn's. no? You mentioned one of the differences is for UC there could be perforation. How about in Crohn's? Can there be perforation? Ira? Hello?
Hello, Doc. Sorry po, di ko narinig. Nag-choppy po.
Sorry. So, hello, can you hear me now?
Yes, yes, Doc.
Pong, can you hear me?
Yes po, Dr.
Okay. So,
Yes
Ira,
po.
okay. You mentioned perforation in UC. Can you see perforation in Crohn's?
Usually po thickening, so it leads to obstruction.
Wait, you answer me first. Can you see perforation in Crohn's?
Question is yes or no. The answer is yes or no.
No.
No?
Yes. The answer is yes.
The answer is
Yes. Ayan yung extent of
Ira,
inflammation mural. Diba?
especially yung extent the extent of the involvement compared to UC, 'di ba? Is full thickness. So you can also see perforation. Now, why will there be obstruction in Crohn's? Next question muna pala. So perforation can be seen in both. How about obstruction? Can you see obstruction in UC also? Can you also see obstruction in UC? Ira? Can patients
Ira,
with
are you
UC present with symptoms of intestinal obstruction? Ira? Are you with us, Ira?
Ay, doktora, umalis. Left the session.
Nawala?
Baka poor connection. Oo.
Okay.
Baka
Sige.
nagka-problem sa connection.
I can go ahead. Doon na lang tayo sa comment.
Sa comment. Dito na lang sa chat. Okay. Okay. Or next presenter, please.
Next.
Okay, Gerald.
So next,
Are you there, Gerald?
yes, Doc. Next,
Sige, okay. Go.
Crohn's disease from ileocecal TB. So, ileocecal tuberculosis is very uncommon. It accounts for 3.5 of extrapulmonary cases, and its main etiologic agent are Mycobacterium tuberculosis and Mycobacterium bovis. And it's acquired through hematogenous spread, swallowing up of infected direct seeding, and ingestion of milk from cows affected by bovine TB. So the difference of ileocecal TB from Crohn's disease are the following. For the site, the Crohn's disease is common at terminal ileum, while the ileocecal TB is common at ileum and cecum. For the clinical manifestation, Crohn's disease manifests as right lower quadrant pain, and it has a systemic symptom such as nephrolithiasis and cholelithiasis. While for the ileocecal TB, it has it manifests as non-specific abdominal pain, fever, weight loss, night sweats, ascites, and pulmonary involvement. For the ulcer appearance, Crohn's disease has a longitudinal ulcer while the ileocecal TB has a transverse ulcer. And for the ileocecal valve incompetence, it is present in ileocecal TB. For the skip lesion, it is common to Crohn's disease and rare at ileocecal TB. For the granuloma appearance, Crohn's disease characterized as single non-confluent, non-cascading microgranulomas, while the ileocecal TB characterized as multiple confluent large cascading granuloma.
Okay, Chanel.
Hello po. Diagnosed together with the laboratory findings and imaging techniques, are all essential in establishing the diagnosis. Findings, there is an elevation of acute phase reactants, decrease in hemoglobin, leukocytosis, hypoammonemia, and elevated fecal lactoferrin and calprotectin.
Choppy. Choppy.
The fecal lactoferrin.
Choppy. Oh.
Hello po, Doc.
Choppy ka daw,
Hello.
Chanel? Parang medyo marami tayong may problema sa audio.
Activated neutrophil.
Choppy.
And it is
Can barely
highly
hear you.
sensitive and hello po.
Yan. Sige, okay.
Go ahead, Chanel.
Sige.
Okay.
Go.
Okay. Fecal lactoferrin is intestinal fecal calprotectin in neutrophils and monocytes, and it is also inflammation and predict relapses of IBD. For the serology, in ulcerative colitis, there is of nuclear anti-neutrophil cytoplasm disease. There is increased level Saccharomyces cerevisiae antibodies, or ESE. We also do stool exam in order to rule out infectious etiologies such as bacteria caused by inflammatory pathogens such as Salmonella, Shigella, and Campylobacter. We rule out also C. difficile toxin because C. difficile membranous colitis, and we also the presence of ova and parasites, and Amoeba and Balantium coli. For our imaging techniques, we use modalities to visualize the IBD. First, for the barium enema, ulcerative colitis and Crohn's disease. In barium enema, there is fine mucosal granulopathy. Here, the yellow arrow would be button ulcers, and also the pseudopolyposis here. For these, you can see the aphthous ulcerations, which was discussed a while ago. Cobblestoning, and the ring sign.
So, Chanel, we have difficulty hearing you actually. Pwedeng pa-check nga yung ano mo, yung audio mo.
Okay po.
Hello?
Hello po, Doc.
Yan,
Can
sige.
you hear me now po? Better. Okay po.
Sige. Okay.
Yes, much better.
So ulitin ko lang po yung sa
Sige.
Crohn's disease po. Crohn's
Sige.
disease, we can see the aphthous ulcerations a while ago, and the cobblestoning, and the string sign due to the which is a narrowed segment of the intestine due to strictures. In the endoscopy, it was already discussed a while ago, the mild, moderate, and severe. We can see here again the aphthous ulcerations and the cobblestoning. So for the it is a good because it is also effective in recognizing manifestations. In UC, we can see the wall thickening here, while in CD, we can see here the enteral fistula between the loops of deceased small intestine. Hello.
Hello, Chanel? Hello,
Naririnig niyo po
Chanel?
ako? Yes,
Nagcho-choppy
Doc.
kasi eh. Baka you have problem sa connection. Hello, Chanel? Hello?
Can we
Chanel,
proceed?
Chanel, maybe you can call up a friend and then your groupmate will put your phone on his mic. Is that possible, Doc Ome?
We can try that, Doctora, but I'm not sure about the quality.
Chanel, are you there? Are you still there, Chanel?
Yes, Doc. Yes po.
Ah,
Hello po, Doc.
yeah, oh.
Okay,
We have
better
a
na.
question here.
Yeah, we can hear
Question,
you.
yeah, question
Better
from
po
Dr.
po.
Chan.
Better.
So do you need to perform all of these tests in patients suspected of IBD? You answer the question of Dr. Chan.
Wish to shape UC from CD po. Not perform all of this po.
Okay, maybe we can
Hello.
proceed.
Next slide. Nagpa-fluctuate eh. Nagpa-fluctuate yung audio.
Yeah, can we move on? Can we move on?
Yeah. Let's move on na lang.
And probably
You
some of
understand
the
naman?
probably can spend a little time on this in our respective small groups if it's okay with
Hello.
the facilitators.
Sure, if
Hello.
they, that's what I would like to say. For those clarifications, for those students who have clarifications on things that were not discussed or expounded upon on the BGD, you can always ask your facilitators in the SGD.
Okay, so this is to no fault naman of the presenter, no?
Of course,
So we know this.
understand.
You understand. So it's okay. Sige. So Chanel, it's okay. So if you have difficulty in your audio, so we can proceed. Na lang doon sa
Chanel, are you there? Wala na.
Oh. Sige. Okay lang. Chanel, it's okay. So ano na lang, we will discuss na lang sa subgroup, no? So, how about let's go to malabsorption?
So, hello, good morning, guys.
Kumusta ang connection mo? This is, introduce yourself.
Doc, Julian Victor Dupaya. Yes, Doc.
Okay. So, okay ang connection? Sige.
Yes, Doc.
Okay, let's
Okay na.
go.
Okay, so good
Yeah,
morning.
kasi we're running late.
Okay, so I'll be discussing malabsorption syndrome. Specifically.
First slide.
Okay, Doc. So the definition of malabsorption syndrome, it is an abnormal intestinal absorption of one or more dietary nutrients, and you need to take note that all cases of malabsorption, all causes of malabsorption syndrome are associated with decreased absorption, except for these two, which are hemochromatosis, also known as iron overload, and Wilson's disease, which is a copper overload, copper buildup. For the clinical manifestations, we have the typical clinical manifestations of malabsorption syndrome are nutritional deficiencies, chronic diarrhea, and steatorrhea. However, in steatorrhea, there are also exceptions. We have primary lactate deficiency and pernicious anemia. Now, for steatorrhea, defined as an increase in stool fat excretion of greater than 7% of dietary fat intake, we have two confirmatory tests. First is the quantitative stool fat determination, which is a stool collection for 72 hours. Then the qualitative Sudan 3 staining, which is more used for preliminary screening. Next, for the more common causes of malabsorption, we have first the celiac disease, which has a hallmark of abnormal intestinal biopsy.
with changes of small intestine upon administering gluten-free diet. Now the problem in celiac disease is gliadin, which is a component of gluten. So this now would lead to wait lang po. So individuals with celiac disease would exhibit an intolerance of wheat, barley, and rye. Next would be tropical sprue. So in tropical sprue, it affects usually expatriates and natives from certain areas. The clinical manifestation would be chronic diarrhea, steatorrhea, anorexia, and nutritional deficiencies. Now, the etiology of this are usually caused by one or more infectious agents such as Klebsiella pneumoniae, Enterobacter cloacae, and Escherichia coli. Next, causes of malabsorption, we have short bowel syndrome, which is a myriad of clinical problems following a resection of various lengths of the small intestine. Now we have to consider different factors that would determine the type and the degree or the severity of symptoms. So first, we need to consider the specific segment resected, also the length and the integrity of the ileocecal valve, which is the muscular sphincter between the last part of the small intestine, the first part of the colon, residual disease, and the degree of adaptation. For the mechanism of diarrhea, there is an absence of intestinal mucosa for absorption, leading now to decreased nutritional absorption. Also, one factor here is the removal of ileocecal valve, because in ileocecal valve it is a muscular sphincter. Now, if it is removed, the bacteria that is in the colon may go back or may backflow to the remaining part of the small intestine, causing bacterial overgrowth there. So next cause of malabsorption also is bacterial overgrowth, which is also called the stagnant bowel syndrome or blind loop syndrome. It may manifest as macrocytic anemia, steatorrhea, and diarrhea. Then bacterial proliferation here in the small intestinal lumen may be secondary to anatomic structures, so such as seen in diverticula, fistula, and stricture, or functional stasis. Uh, Next would be Whipple's disease, which is a chronic multisystemic disease. The hallmark of Whipple's disease is a positive periodic shift, foamy macrophages in the small intestine. The causative agent is Tropharima whipplei. GI findings plus migratory large joint arthropathy, ophthalmologic and sinus symptoms are found. For lastly, protein losing enteropathy. We have a group of GI and non-GI disorders with hyperproteinemia and edema. So here we can expect an excess protein loss into the GI tract. Diseases that may manifest increased protein loss are mucosal ulceration, non-ulcerated mucosa, and lymphatic dysfunction.
Okay.
So, diagnosis of malabsorption. So, the initial workup would include complete blood count, serum iron, cobalamin, and folate, serum albumin, alkaline phosphatase, and proton. Routine laboratory studies may suggest dietary nutrient depletion, and especially the deficiencies of vitamins D and K, and iron, folate, and cobalamin. So, provided by history, symptoms, and initial preliminary observations, we can also do other studies such as number one, urinary D-xylose test, which is a test for carbohydrate absorption. And this test can provide an assessment of proximal small intestine mucosal function, since xylose is a pentose which is almost exclusively absorbed in the proximal small intestine. This test is usually done by administering 25 grams of xylose and then collecting the urine for 5 hours. An abnormal test, which is defined by an excretion of less than 4.5, would primarily reflect duodenal or jejunal mucosal disease. And this test can also be abnormal in patients with blind loop syndrome and also as a false positive study in patients with large collections of fluid in the third space, such as in cases of ascites and presence of pleural fluid. And this is the Schilling test. So this test is used to determine the causes of cobalamin malabsorption. And this test has 4 stages, which would require the patient to fast for 8 hours. So in stage 1, the patient is given radioactive labeled cobalamin, and if there is a deficiency of B12, then the excretion of the percentage of administered B12 in a 24-hour urine collection would be low. So if
I don't
stage
think we
1 results
those technicalities, Dr. Early. Okay.
po,
Can we just proceed to the next slide, please?
No need to discuss in detail. So, okay. Next.
ito po, Doc.
Okay.
Okay, proceed.
Okay. Doc, ito po ba? Or wag na po?
Sige, okay, go. Just run the,
So,
andun lang.
Huwag
okay,
na
so
yan.
lesion,
Yung susunod na.
Yung last mo na.
Yan.
Yan. Sige.
So for the specific malabsorption diagnosis, as outlined a while ago, celiac disease, you would use biopsy and serology with immunologic and clinical response to gluten-free diet. And histologic changes would include a number of intraepithelial lymphocytes and absence of reduced height or villi, and also cuboidal appearance, and the nuclei is no longer oriented basally in surface of epithelial cells. Next, for tropical sprue, the biopsy results for tropical sprue would be similar to that of celiac. And this time, you have no response to gluten-free diet. And for Whipple's disease, you would also use biopsy, which would reveal PAS-positive macrophage. And for bacterial overgrowth syndrome, the diagnosis may initially be suspected if you have a combination of low serum cobalamin levels and elevated serum folate. So you use breath hydrogen test with administration of lactulose. And for protein-losing enteropathy, you use serum albumin in given that there's absence of renal and liver diseases.
Yes po, Dr. Ruiz.
Yeah, just for the group, no, the reason why we are not letting you present in depth of some concepts is that at this stage, they are not must know to you. Okay, I hope you understand that. What are must know are the things that we emphasize here in the BGD. So it's good that you know the principles in the approach for malabsorption as a cause of chronic diarrhea, but to go in detail of all those things is nice to know for you. Okay, so we hope you understand that why we are skipping on some slides or presentation that you have prepared for the group. So it's just a guidance from your faculty. Okay.
Ay,
You
thank you
can
po,
go.
Doc.
Okay, thank you, Dr. Sige.
So for the treatment of malabsorption, so more than 90% of patients who have the characteristic finding of celiac disease respond to complete dietary gluten restriction. The remainder constitute a heterogeneous group whose condition is often called refractory celiac disease that includes some patients who respond to restriction of other dietary protein like soy or glucocorticoid treatment. Other therapeutic approaches include the use of peptidases to inactivate toxic gliadin peptides and of small molecules to block toxic peptide uptake across intestinal tight junctions. So for tropical sprue, tetracycline is the most commonly used antibiotic. It should be used for up to 6 months and may be associated with improvement within 1 to 2 weeks. Folic acid alone induces hematologic remission as well as improvement in appetite, weight gain, and some morphologic changes in small intestinal biopsies. Because of marked folic deficiency, folic acid is most often given together with antibiotics.
Yes po, Dr. Chan. Dr. Chan, yes.
I think that before they are going again to the specific diseases and their specific treatments. We're talking about chronic malabsorption in this case. So there's usually a general management of patients presenting with malabsorption. And that of course is more important than going to the specifics. You have to give the general treatment first. In fact, for the specifics, you can just say that for the specific diseases, there would be specific treatments depending on, of course, the diagnosis that is established.
Mm-hmm.
So
Doc, for the
how do we deal in general with patients with malabsorption?
Doc, usually po these patients would present with diarrhea. So usually these symptoms will be addressed first. So um if mild po, usually loperamide may be used, or if severe, codeine or opioid.
Yes, because you're talking here about the nutrition of the patient, the vitamin deficiency, the anemia, the electrolyte imbalance. This is part, and this could have been just one slide on the general management of patients presenting with malabsorption.
Yes, okay po, Doc. Yes po, Doc.
Do you have a slide on the general management?
No po, Doc.
Okay, so
Oh,
if you don't have that slide, can we just go straight to your causes of malabsorption syndrome and just state what is the treatment? Okay, you don't have to go through the details. So, for example, celiac, non-tropical sprue, then tetracycline, folic acid, etc. Okay,
okay.
so continue.
Okay.
So for short bowel syndrome po, usually we can do dietary changes or opiates if the patient would present with diarrhea, PPI, and vitamin and mineral replacement therapy if indicated. So like what Doc said, if the patient's vitamin and mineral status uh, is not um, okay, these would be replaced with parenteral nutrition as well.
Okay, next.
Next disease.
So for bacterial overgrowth syndrome, so you have two causes, your anatomic and your functional. So for your atomic, you just do surgical correction, and then for your functional, you give broad spectrum antibiotics. And then for Whipple's disease, ceftriaxone or meropenem is given for 2 weeks, and then oral trimethoprim sulfamethoxazole twice a day for 1 year. Or if trimethoprim sulfamethoxazole is not tolerated, chloramphenicol may be given.
Okay. Next slide.
So, for protein-losing enteropathy, doc, you usually just treat the underlying disease and not the hypoproteinemia itself.
Okay. So before we go with IBS, I think this is fair if we can give Janelle a chance to present at least her last two slides on the management of IBD.
Hello po,
Very brief
Doc.
lang. Sige, very brief lang, Janelle, ha?
Okay po.
Sige,
Clear
let's
na
go
po
back
ba?
to the... Yes, yes, we can hear
Clear
you.
na po. Thank you po. Sorry
Yes.
po for the
It's
technical
okay.
difficulties.
So, okay. Sige na. So, discuss briefly the management. Okay.
Okay.
Okay, dito na po, Doc. So,
Yes.
Sige,
based
go.
on the clinical features of the patient, since the patient has loose motion mucoid stool, hypogastric pain, and rectal tenderness, um, the manifestation points to ulcerative colitis rather than Crohn's disease po. And the patient, this is the disease presentation of ulcerative colitis, and the patient has a mild to moderate ulcerative colitis since the patient had only 3 to 5 times bowel movement. The patient has blood streak tools, and the patient has low-grade fever and is not tachycardic. Therefore, um, the patient is classified to mild to moderate UC. So here is a figure taken from Harrison's. Drugs from the bottom part of each pyramid are the drugs of choice, while the ones above are the alternatives. One that's below on the pyramid does not improve the patient's condition. So for mild to moderate ulcerative colitis, the drug of choice is 5-aminosalicylic acid, orally or rectally. We can use sulfasalazine, and the dosing per day would be 3 to 6 grams orally and 3 divided doses daily after meals po. For maintenance po, we can give 2 to 4 grams of sulfasalazine. Also, we can give suppositories to improve the ulcerative colitis. For mild to moderate Crohn's, the drug of choice would be budesonide. For moderate to severe ulcerative colitis, the drug of choice would be the glucocorticoids. For moderate to severe Crohn's disease, we can use the immunosuppressants such as 6-mercaptopurine and azathioprine. And for the fistulizing Crohn's disease, we can give the patient antibiotics such as metronidazole and ciprofloxacin, and we can also do drainage of the abscess.
Okay, your next slide.
Tell us about the monoclonal antibody.
Oh, so question for Mel, how about the monoclonal
It's
antibodies?
very important.
Okay po, Doc.
You
go back
to
to
your previous slide.
Doc, for the monoclonal antibodies po, we can give infliximab po. It is used for moderate to severe Crohn's disease po.
So what are these? What are these monoclonal antibodies? Specifically infliximab.
Doc, infliximab, golimumab po, and certolizumab and adalimumab po.
Ano yung effect nila? They are infliximab is what?
Anti-chronic necrosis factors po. Anti-TNF.
No?
Okay.
Okay na po, Doc.
Yes.
Okay.
Okay po. For the nutritional therapy and in Crohn's disease, the patient responds well to bowel rest and total parenteral nutrition. However, in ulcerative colitis, the inflammation is not reduced with dietary interventions. For surgical therapy, the choice would be proctocolectomy with ileal pouch anal anastomosis or IPAA. So here, we remove the whole colon and the rectum.
Yes, Doctora. Doctora Ruiz.
Yeah, I think we stop there, Chanel. No need to discuss the surgical technique. Now, what we want from you now is, since you are the last speaker, why do you think we should consider IBD as the cause of the patient's chronic diarrhea?
Doc, because po, the patient has mucoid stools and rectal bleeding po, which was seen on the digital rectal examination po.
Okay, what between UC and Crohn's, what do you think is the most likely?
So the most likely po would be ulcerative colitis, Doc, because the patient presented with no palpable mass, and in ulcerative colitis, the presentation is same with the patient's manifestations such as mucoid stools, Mosher stools, crampy, hypogastric pain, low-grade
Now,
fever.
these are all present also in Crohn's. Is there anything in the physical exam of this patient that would tell you that more likely it is UC than Crohn's because of the involvement of that segment of the lower GIT?
In the terminal ileum po.
No. That is absent in your patient. What is present in your patient?
Look at your PE. Is there any?
Blood, there is presence of blood po in the digital rectal examination po.
In the rectal, presence of blood, di ba? Pwede pareho. UC and Crohn's.
Yes, Doc.
Other than the blood. Other than the presence of blood.
What is the other finding in the rectal
rectal
exam?
tenderness, doc.
So,
So
if there's rectal tenderness,
it
that
points
means there is involvement of the
of the rectum and
Rectum.
rectum and colon.
Okay.
oh,
And do you have
Because
oh,
And
ulcerative colitis, it usually involves the whole colon.
okay.
no. In ulcerative colitis, it starts from the rectum going up diffusely. But in Crohn's disease, you have rectal sparing, di ba?
Okay po. Yes.
Okay.
Yes.
Okay.
Noted, doc.
Okay, so next.
Okay. Sige.
Thank you po.
Okay. Sige.
The
Yung last member nung
yeah. Okay, Pong.
yes. Last member of the malabsorption group.
Yes, Doc.
Yes.
Hello.
So,
Why do you
do you think that they
consider
have malabsorption? Malabsorption.
Doc, we considered malabsorption because the patient presented with diarrhea, loose stools, a low BMI which may indicate weight loss, and hypogastric abdominal pain. Patient also reported travel history from Bangladesh, which may be a factor to consider for diagnosis of tropical flu. Patient presented with pale palpebral conjunctiva, which is a sign of anemia and may indicate cobalamin, folate, or iron malabsorption. The patient did not present with any palpable mass and tenderness, which are both not seen in patients with malabsorption, Doc.
Okay. Thank you. So, let's proceed with the last group, IBS. Okay. Sige, IBS.
Okay. Just a short introduction. Irritable bowel syndrome is a functional bowel disorder characterized by abdominal pain or discomfort and altered bowel habit structural abnormalities. So there are no clear diagnostic markers that exist for IBS. Thus, the diagnosis of the disorder is based on clinical presentation and the wrong diagnostic criteria. So symptoms come and go and often overlap with other disorders such as your fibromyalgia, headache, backache, and genitourinary symptoms. So, according to Harrison's, irritable bowel syndrome affects all ages. 10 to 20% of adults and adolescents have symptoms of IBS globally in women than in men. In the meta-analysis study by Lovell and Ford, if you can look at table 2, the world prevalence is at 11.2%, while in Southeast Asia, we have the lowest at 7%. But we must not take note that this meta-analysis is done by geographical location and therefore doesn't provide exact prevalence rate by country. Now in Table 5, their meta-analysis study is comparable with the epidemiological data given by Harrison's. With respect to age, prevalence becomes lower as the subjects gets older. This can be due to the under while in gender, women have higher prevalence in men.
Okay, next.
So since there is a little difficulty from retrieving local studies regarding irritable bowel syndrome, I retrieved records from PhilHealth through the government's Freedom of Information page and took the liberty of making a simple graph to present the data. So from 2015 to 2017, there were 597 cases of irritable bowel syndrome reported by PhilHealth with a mean age of 40 years. So apparently in 2015, Region 2 has the most cases, and in 2016 and 2017, Region 1 has the most cases. Uh, Next.
So, hello? Okay po ba yung
Okay.
audio?
Yes.
very
So for
good?
the criteria,
Very okay. How will we call you? Mary? Francesca.
Cheska na lang po.
Francesca, very okay.
Okay pa. So,
Go ahead.
for the criteria for diagnosis of IBS, so because IBS is mainly a disorder for which there's no pathognomonic abnormalities present, so it's mainly a functional disorder. So the importance of which is true recognition of positive clinical features, followed by elimination of other organic diseases. So that's why careful history and PE is of utmost importance for the diagnosis of IBS. So there are several symptom-based criteria that have been developed, and for this discussion, we will mainly focus on Rome 4 diagnostic criteria, which was published on 2016. So the Rome 4 diagnostic criteria assesses IBS based on the abdominal pain and altered bowel habits that occur with sufficient frequency in affected patients. Okay, so Rome 4 diagnostic criteria assesses IBS, so through the presence of recurrent abdominal pain on average at least 1 day per week in the last 3 months, and is associated with greater than or two of the following criteria. So the recurrence of abdominal pain should be related to defecation or associated with the change in frequency of stool or with the presence or form of the stool. So for the next slide, so these, in addition to the Rome 4 criteria, so these suggest clinical features that are associated with IBS, while on the other column, so it suggests features that are opposed to the diagnosis of IBS. So these include recurrence of lower abdominal pain with altered bowel habits over a period of time without progressive deterioration. So the patient's symptoms are present during emotional upset or stress. So there's absence of other systemic manifestations such as fever and weight loss, and the presence of small volume stool without any evidence of blood. So for the features that are opposed to or against to the occurrence of IBS, so these includes appearance of disorder for the first time in age. So there's progression of the disease, persistence of diarrhea after a 48-hour fasting, and presence of nocturnal diarrhea or the steatorrheal stools. So for the diagnostic considerations of IBS and workups, so we must know that there are few tests that are required for patients who have typical IBS symptoms with no alarm features. So why is that? So it's because extensive use of diagnostic tests may be expensive and can actually be harmful to the patient. So however, for the patients that present with IBS-like symptoms but with alarm features or red flags, which are noted in the following figure. So this may prompt or warrant more investigation. So the additional alarm features have poor diagnostic utility such as nighttime symptoms, which may be present both on IBS and other organic diseases, and the risk of organic diseases increase with advancing age in such a way that for younger populations with milder symptoms, they require minimal tests, but for those who are of older age group with progressive deteriorating symptoms, they require more aggressive diagnostic tool in order to exclude other organic diseases. So according to American Gastroenterological Association, so these are some of the factors to consider for determining the aggressiveness of diagnostic evaluation, which includes duration of symptoms, change in symptoms over time, age and sex of the patient, referral status, the family history of colon cancer, and the degree of psychosocial function. Hello.
I think you need to emphasize your go back to your previous slide. You have to emphasize this one, the alarm features.
Yes, Doc. So the alarm features consist of the following characteristics present in the patient. So for our patient, so her history includes blood, the visualization of blood in stool, so the chronicity of diarrhea. She had low-grade fever, and she was said to have traveled to Bangladesh, which is associated with with populations having high degree of chronic diarrhea due to infectious causes. So there's also the presence of overt blood or mass on rectal examination. So that's why for our patient in this case, we need there's a warrant more of investigation in order to exclude other organic causes because of the presence of such alarm features in the patient.
Okay. Next.
Hello po. Rinig po ba ako?
Yes.
Okay.
Sharika.
Yes po.
Sige.
Since
Okay.
IBS is a disorder with no specific pathognomonic abnormalities, so functional siya, the treatment strategy depends on the
Sharika,
severity.
a little louder lang.
Sorry po. The treatment strategy, okay na po, Doc?
Yep.
Yeah.
depends on the severity of the disorder. In summary, Doc,
Hindi, man. Okay lang yan.
okay po.
Just go with your presentation.
Okay po. Which mainly focuses on the relief of symptoms experienced by the patient. So since most IBS patients have mild symptoms, the mainstay of treatment involves patient counseling and dietary alterations. So there should be reassurance and careful explanation of the functional nature of the disorder. The patient should also be advised to avoid food precipitants which may be revealed through dietary history. So examples are coffee, disaccharides, legumes, cabbage, and those containing excessive fructose and artificial sweeteners. Fermentable oligosaccharides, disaccharides, monosaccharides, and polyols or FODMAPs are poorly absorbed by the small intestine. So they are fermented by bacteria in the colon to produce gas and osmotically active carbohydrates, leading to abdominal distension. And these events, these three, act in concert to cause bloating, flatulence, and diarrhea. So FODMAP may also serve as nutrients for colonic bacteria, which may induce mucosal inflammation. Therefore, a low FODMAP diet has been shown to be helpful in IBS patients, since a diet rich in FODMAP often triggers symptoms in IBS. A smaller portion of patients have moderate symptoms that are usually intermittent and correlate with altered gut physiology. For example, those worsened with eating or stress and those relieved by defecation. So pharmacotherapy is given depending on the type of IBS the patient has. So if the patient has IBS diarrhea predominant or IBS-T, we can give antidiarrheal agents like loperamide, which binds to opiate receptors in the gut wall, slowing intestinal motility and affecting water and electrolyte movement through the bowel. Loperamide is most effective when taken prophylactically and has a lower risk of inducing dependence, unlike opioid agonists. We may also give antispasmodic agents like dicyclomine or hyoscine, and these are used for smooth muscle relaxation through inhibition of the muscarinic cholinergic receptors in the entire plexus and on the smooth muscle, therefore relieving symptoms such as painful cramps. And these are more effective when prescribed in anticipation of predictable pain, so they are given 30 minutes before meals. Since 30% of patients diagnosed with IBS-D present with bile acid malabsorption, and bile acids are known to cause colonic secretory diarrhea, a bile acid binder like cholestyramine may be given to prevent bile absorption. Hence, the cholestyramine bile acid complex is excreted in the stool. 5-HT3 receptors enhances the sensitivity of afferent neurons projecting from the gut, so we can give 5-HT3 receptor antagonists like allosterone, which reduces perception of painful visceral stimulation in IBS and induces rectal relaxation, increases rectal compliance, and delays colonic transit. So if the patient has IBS constipation predominant, sige, hyoscyamine po. Okay po, Doc. Sorry po. So if the patient has constipation predominant or IBS-C, we can give stool bulking agents like psyllium or bran.
Yes, Doctora.
We can
Question
skip
from
this.
Doctora Ruiz.
Skip na po to, Doc.
Oh, kasi diarrhea naman yung presentation eh.
Hirap
Sige.
tayo.
Sige po.
Next. Yes po, Doctora.
No. I just, napindot lang. Go ahead.
Okay. Go ahead.
Sequence for IBS. So basically, the patient should be treated depending on the predominant symptom. Then you adjust the treatment accordingly if there is no response. So this is just like what I said earlier. But since abdominal pain is a prerequisite for the diagnosis of IBS, I would like to reiterate that as first line of treatment, we give antispasmodics or peppermint oil. And if the patient is refractory to treatment, we can give the second line, which are the antidepressants like TCAs, SSRIs, or psychological therapy. So the antidepressants are given in low doses, reducing the intensity of pain signals going from the gut to the brain.
We have a question from Dr. Chan.
Yes po.
So you answered the question of Dr. Chan. How about the use of pre and probiotics and also rifaximin?
Wait lang po.
After that, so Dr. D also has a question.
Do you have that?
Doc, according po
I think that
sa
nandiyan na sa first sa bloating.
opo, so for bloating po. Second step po siya for bloating, for the treatment of bloating po, Doc.
Okay.
Hello?
Dr. D?
Yeah, and also rifaximin for IBS diarrhea. Additionally, let me ask you. I was looking at your slide. You said here fiber supplement for constipation. Can you use fiber for diarrhea?
Mm,
Answerable by
Doc,
yes or
think,
no.
yeah, I think po yes po, Doc.
Okay, you can also use
Yes.
fiber for
Yes.
diarrhea.
Yes.
Diba? The objective of the fiber is to absorb liquid. Diba?
Yes.
So it's not only to make the stool soft, but rather to absorb liquid. So in any case, even for diarrhea or constipation, fiber can be used. But just a little bit of a favorite word of Stephen Wong, which is, ano nga yun? Warning?
Caveat.
Caveat.
Caveat. Caveat using fiber are in patients with a lot of bloating because one of the complications of fiber. Okay.
Okay. Sige. Okay, so why do you think your patient has IBS?
Doc, we considered IBS po for diagnosis since she has crampy hypogastric pain, and pain po is prerequisite po for IBS. Also, yung alteration of bowel habits po, which is the chronic diarrhea for 2 months.
Well,
But,
Yes,
yeah,
but
sorry. But you remember that the previous speaker was talking about blood in the stool?
Yes po.
And she mentioned that it is not IBS. How you can reconcile this? You say this is IBS because of the diarrhea and because of the chronicity, but how can this be IBS if there's blood?
In other words, you have
Doc,
an alarm symptom.
yes po. So, Doc, yung IBS po kasi wala po talaga siyang bleeding, pero it is unusual unless it has coexisting hemorrhoids po.
Okay.
Okay. Sige.
Okay, agree. We agree. Okay,
Oh,
so
last
yung last
member
member of the group.
Okay po,
Carlo.
Doc. So for the diagnosis of the patient, so because of the blood streak stools and the blood on the DRE and the rectal tenderness, you could see that it's more pointing out to the inflammatory bowel disease, and as to the two types, your ulcerative colitis and your Crohn's disease. So as stated earlier, because of the rectal tenderness, which states that meron pong rectal involvement, which is not seen in Crohn's. So the most likely diagnosis is chronic diarrhea secondary to ulcerative colitis po, Doc.
Nalito ko dun. Okay.
Sorry
Ano mo
po.
muna? Ano mo muna? Is it IBD?
Yeah.
Yes po,
IBD
Doc.
before you
IBD, Doc. Due
differentiate
to the...
UC versus Crohn's.
Okay po, Doc.
Kasi
So, it's
dumiretso ka ng
IBD.
dumiretso ka ng UC eh.
Okay po. So, this is IBD due to the blood streak stools. As mentioned earlier, dun po sa alarm po ng IBS, there is no... if may blood streak stools po, parang you will rule out IBS. You will see another organic cause of the disease. So, rule out na po yung IBS. Then, for the malabsorption, wala din po siyang blood in the stools, and so more of IBD po siya. So, next po nun is
Rather
it
than
ulcerative colitis or
sorry.
Crohn's?
Charlotte, rather than,
Yes,
gaya nung sinabi ni Dr. Ruiz a while ago, no? Rather than ruling out the other diseases. So why do you
Okay
think
po,
that
Doc.
this patient has
It's
IBD?
IBD po, Doc. Doc, due to the blood streak stools, rectal tenderness, flesh blood on our DRE, it's more, and fever po, Doc, which can be pointing more of an inflammatory in nature po, Doc. So, inflammatory bowel disease po, Doc.
Okay na?
Okay po, Doc.
Okay, so there are other comments? Okay, so great. Congratulations to the two groups.
Yeah.
So,
I hope
kung
your classmates have learned from this. And I'd like to congratulate all the presenters for the preparations they made.
okay, so we'll proceed now to the different SGDs, no? So, kanya-kanya tayo. Okay. Thank you,
All right.
guys. Thank you.